Awesome. Hello, everyone. As I said, my name is Lucas, student physiotherapist, soon to be graduate physiotherapist from Brunel University, London, working here in Vernon and through Fort McMurray at Clearwater Physical Therapy to bring you a little mini lecture series on various nuances of pain, called the lecture series Unmasking Pain, as part of the fun trendiness that is the pandemic in this current state. Today's lecture, we're going to be touching on a couple different topics. Psychology of pain is kind of the general theme, though. So let's get us started. Briefly, we're going to have a bit of an outline just to cover what we're going to be talking about today. First, we're going to touch on the brain. Last week, we touched on more of the nervous system and broad strokes, how it works. We're going to delve a little bit more into the different areas of the brain and how they function such that we understand how it can color our experiences. We're going to take a bit of a step away from kind of the anatomy stuff and move towards more of this narrative psychology bits, discussing the stories we tell ourselves and the fear avoidance model and the linguistic effects of our perception and our experience of pain and how those can actually impact that experience and color it to make it more or less intense. We're also going to touch on aspects of the stories other people tell us, so the things that our families, friends, social circles, medical professionals, whomever that might be, affect our pain. We're going to touch on little bits about social learning and how that can affect our interpretation of our lived experience, the understanding of your condition itself and how that can affect it, and as well, we're going to just give you a little bit of an idea of something you could work on outside of this little lecture series if you want to, about narrative reflection and exploring what we think about pain or what you think about pain. So let's get started. I'm going to do a couple little review things just to start. We're going to touch on what pain is as a definition. Pain is an unpleasant sensory or emotional experience associated with or resembling that associated with actual or potential tissue damage. It's a big, broad strokes term that essentially tries to explain pain as something that can be associated with an injury, but may no longer be associated with that injury. We can, just as much as we can feel pain from having a cut or a bruise, we can also feel pain emotionally from loss or grief or uncertainty or anxiety or depression, whatever that might be. In the context of pain in the description of this lecture series and persistent pain, often these sensations or perceptions are actually related to potential tissue damage or resembling that associated with potential tissue damage, which touches on those acute versus persistent pain concepts. Acute pain usually often is related to injuries or things that last less than 3 months. It is tied to a direct location, a direct insult, that's a bruise, that's a cut, that's a stretch, that's a strain, versus persistent pain, which tends to be related to things that aren't directly tied to an injury. It's related to things like changes to our nervous system and our sensory systems that make our body more receptive to threat and interpreting that threat as this pain perception we experience. Another important aspect to understand is the nerve in and of itself. So we're just going to give a little bit of a brief discussion of what the nerve was, reminding us from last week. A neuron, more specifically, is the fundamental building block of that nervous system. They connect to one another via synapses, little junctions, and they conduct information along these long thread-like structures called axons or dendrites, creating these long networks that allow us to move our muscles, move our joints, feel, learn, experience the existence that we live in today. Nerves, as a structure, are bundles of these long thread-like structures tied to these neurons that can send information to our central nervous system, the brain and the spinal cord, or they can send information from the central nervous system out to the periphery to allow us to respond to things, to allow us to be aware of sensations as they come to different areas. Cool. Really quick and dirty versions of those two different definitions, just to give you a reminder. We're going to move forward into the aspects of the brain now. The brain itself is a relay and response center. It's an important center and it helps to integrate information. Different areas of the brain, as this weird complex structure here indicates, are responsible for interpreting different stimuli or experiences or sensations that come from the spinal cord and all of our sensory structures, and processing that information such that we can create appropriate responses. Now, there's a big list here of different regions. We're going to kind of touch on them briefly here, and I'm going to go into kind of a visual interpretation of these as well. Big ones to note are the somatosensory cortex. Last week we discussed this. This is where the virtual image of our body is stored, where what our brain and our internal systems think of as our bodies is interpreted and sensed. The amygdala, if you've heard it before, it's usually related to things like fear, but it's also related to learning. The thalamus is a center for relaying information from the spinal cord or from the body to the brain and vice versa, and as well between different areas of the brain. The prefrontal cortex has this fancy term they like to call executive functioning. This is our higher center learning. This is our interpretation of experiences. This is our ability to figure out social or create judgments and create or weigh our options and things like that. The two right here, the periaqueductal gray and the rostral ventral medulla, are kind of regions in the brainstem more so, and these associated areas that allow for a variety of functions. They act as relay centers as well, but they can also change the information that is being conducted through those relay centers such that it can increase or decrease sensation. As well as the idea of reward centers. There's lots of them, and they're in different areas of the brain, and they provide positive reinforcement and pleasure perceptions, or positive interpretations of the information that is being processed in those zones. So let's take a little closer look. This is the brain. Nice little cross section here. This little highlighted area is the thalamus. Information will come from the spinal cord. Let's say we have an injury in our hand. That information will go through a neuron, conduct along the arm to our spinal cord, come up through the spinal cord, relay with a couple different neurons, and enter the thalamus. The thalamus will then relay that information to different areas of the brain such that we can respond to that sensation. After it's been integrated in regions like, excuse me while I move this, the somatosensory cortex, this area wherein we house our virtual image of our bodies that maps where we feel sensations to our understanding of what our body is, as well as things like the prefrontal cortex to understand the context of that injury. Is it going to be significant? Is it insignificant? Is it going to impact us directly right now? Is it going to have long-term effects, short-term effects, how we feel about being injured? All of these kind of interpretations occur in this area and others, but this is one of the big ones. The other region here, it's kind of marked not related to the specific structures on this image. It's the amygdala. They're actually kind of essentially from the midpoint just off to the sides. And the amygdala is a center related to significant emotions, very big responses, things like fear, pardon me, that's there. Things like fear, things like uncertainty, things like pain, and those type of interpretations create really strong memories in the amygdala and the associated learning and memory areas. So let's give an example. We have an injury that occurs to the hand. It comes down through the brain, or through the nervous system to the spinal cord, up into the thalamus, where it is relayed to all these different regions. Our prefrontal cortex interprets it. If the injury was traumatizing or scary, sometimes the amygdala will interpret it faster and create a memory, an idea or a connection between two different areas, such that if you feel that area is being threatened on your hand again, the amygdala will fire and will have a frightful response or a painful response to that stimulus. Other areas to include these guys. The ventromedial prefrontal cortex is one of these that will be tied to the amygdala as well as our emotional interpretation of things. The ventromedial prefrontal cortex, this region is an emotional region. It creates our memories related to emotions and feelings. It creates memories related to social norms and what we're expected to do and what we expect ourselves to be able to do. It houses our personalities and our identities, as well as other regions in the brain. So can come back to that example, if you hurt yourself, how you interpret that information when it comes as a pain or as a threat stimulus through the thalamus and to all these other regions. The ventromedial prefrontal cortex will color that experience such that we contextualize it in our lives. This could mean that if we injured our hand, suddenly we start thinking about things like, am I going to be able to engage in the things I like to do? Or am I going to be able to get back to work? Am I going to be able to walk the dog? Am I going to be able to do whatever aspect of life that might be? This is an area that type of processing can occur. And this prefrontal cortex is tied to all these other areas as well. There's a lot of connections between these different regions through the thalamus or through other areas. The periaqueductal gray, this little guy right here, and the rostral ventral medulla are actually more of a modulating centers. They tend to take information that's descending from these bigger areas down back to the spinal cord and down through the rest of the body. The rostral ventral medulla actually can filter information such that it reframes an injury or reframes a sensation. So if you're experiencing a lot of pain, and you think about that pain and you go, okay, maybe I can actually work through this or manage it successfully and still be able to live my day, this little region of the brainstem can actually decrease the pain perception signal that you would be experiencing otherwise. Periaqueductal gray can do very similar things. All of these areas are very tightly connected. Lots of associations between the thalamus, which is that relay center, to all of these different ones, the somatosensory cortex, the prefrontal cortex. This is just a small number of arrows. The brain is a hairball. Everything is connected to one thing or the other. And especially interesting is every individual's connections will be slightly different, which means things like sadness or happiness or the experience of pain, as we're discussing kind of in this general lecture series, will be flavored and contextualized differently based on the connections within your own nervous system. So if you have an understanding of pain as something that you can work through, or you have a learned experience that says, I have worked through pain before or it's disappeared, that will change the feeling of pain that you have, because the areas within certain parts of the brain are more adapted to understanding pain that way rather than experiencing it in another context. So that's a quick and dirty version of some of the centers related to pain. We're going to touch on a little bit of a different topic now. This is more about the psychology and the sociology of pain, understanding language and how that affects your ability to feel pain and other things. So the brain itself is obviously a learning center. Everything that we describe and how we think about things will be processed within this brain, and the amount we think about different things will change the efficiency of those pathways. So to give an example, if we constantly think about how hungry we are, suddenly that pathway becomes more active and we become more hungry constantly. If we think about how much pain we're in, the pathway that we're always stimulating, that pain pathway, that recognition of pain pathway, that fear of movement pathway, will become more efficient and change the way that we experience that sensation. Our internal dialogue, that description and linguistic understanding of an experience, in this case pain, will affect how we perceive and respond to that sensation. A very simple model of this to talk about these internal dialogues is this fear avoidance model. We talked about it in the first lecture. I'm going to review it right here. This is the little flow chart for this thing. So in the context of pain and the learning brain, we have an injury. Let's say we hurt our hand, as I've been using as an example. We have a pain experience. Our hand has detected threat as a sensation, and our brain, after it's been processed, interprets this as pain and sends that information to that area. So suddenly this area becomes very sore. Depending on how we understand that sensation of pain can influence which way we can go on this little flow chart. If we recognize that that is just something that occurs secondary to an injury, and it will change in the same way that healing occurs, it decreases our fear. And we can confront that sensation and we can confront that change in our bodies to allow ourselves to recover more effectively. If, on the other hand, we consider it and we become terrified or traumatized by the thoughts and feelings we have about that injury, the concerns about being able to get back to work or get back to life or get back to whatever other thing we might want to be doing, suddenly that creates an anxious pattern that reinforces that internal dialogue that changes the sensation of pain we have. This negative affectivity here is those negative thoughts and feelings and emotions related to that experience. This anxiety and this worry about what could happen in the future can create pain-related fears. If I injure myself, I'm not going to be able to do the things I used to be able to do. If I re-injure this hand before it heals, I won't be able to use it and I won't be able to do the things I do either. This can create a pattern of avoidance. Rather than doing the thing that's useful and confronting our injury and looking for rehab options, we create avoidance. We hide from the things that we want to do. We stop using this hand. We become hypervigilant of it becoming sore. We become aware of every single sensation that we have in that area. This is that part of that reinforcement pattern. If we're hypervigilant of mainly that pain sensation and the worry that we're going to re-injure that area, it will facilitate that sensation of pain that we have in that region. This can create a vicious cycle of disuse, disability, and ultimately a bit of depression because we're not able to do the things we used to be able to do. By extension, that disuse and disability will increase our pain experience because when we try to go back to the things we used to be able to do after the injury initially has healed, we can no longer do them. And the sensations that we've been facilitating, this avoidance and hypervigilance, we become more aware of any sensations we have in that area as pain, which feeds back into this loop. So part of our learning brain's responsibility and part of our body's responsibility is to try get into this other pathway, to recognize that we can have less fears, or we can be anxious, but we can know that we can heal if we confront that injury or confront that issue. In the context of persistent pain, it's taking that time to step back and go, things can change, and our bodies can change, and the way we think about our experience can change as well. And we can lead to a little bit more recovery. So let's look at a couple different examples of narratives and things the learning brain or our own brains can tell ourselves that will impact our pain. They all fall into this kind of model. An example that we can sometimes tell ourselves is my body is fragile, and I should limit the movement to prevent damage. This is a narrative that can occur if we've had a recent fall or an injury, or we've been told that bone mineral density is low or what have you, or that an area is really fragile after an injury. These type of dialogues will feed into that negative feedback loop because we stop using our bodies because we don't want to hurt ourselves more, when in fact it should be the opposite. We should be moving towards graded activity. We should be moving back towards mobility in order to become stronger to prevent damage, rather than stopping moving, deconditioning, and actually creating that self-fulfilling prophecy and making our bodies more fragile ourselves. Other narratives include things like it hurts to move, so I must be damaging myself more. And this one comes into play in a number of contexts. Osteoarthritis is a big one, especially as our bodies change as we age or shift or are prone to exercise. If we have an area that is sore, it may not be that there's an injury. It might just be that there are nerves that are being sensitized in a region because of physiological changes in that area. There may be no damage anymore. There may not be any changes to the tissue that are occurring. It might be that our nervous system is firing and our brain is interpreting it quickly as pain. To have a dialogue that says we are damaging ourselves more facilitates that negative feedback loop of hypervigilance and avoidance and deconditioning that will ultimately actually make it harder to move in the first place and increase the likelihood that you could damage yourself. So in the same way that we create that negative feedback loop about being worried about being fragile, we can also create that feedback loop by being worried about our experience of pain and the amount that we could damage ourselves, which may not be true. Other things we can describe: if the tissue is damaged permanently, my pain will never go away. And this one's really quite interesting because often we get things like scans or imaging that show changes to our bodies, show age-related changes to bones, to joints, to our lumbar spine, our discs, to vasculature, to our brains, whatever it might be. And more often than not, those images aren't necessarily correlated with the symptoms that we experience. There's a really interesting study that was done, and after the age of about 50 or so, more than 70%, odds are more close to 90%, of individuals actually show age-related changes to their lumbar spine and their cervical spine. And most of the population actually doesn't experience anything related to those permanent tissue changes, which indicates that tissue change isn't related or isn't directly tied to our pain experience. And by extension, that our pain experience may be changeable despite no changes to the tissue occurring. An important distinction to recognize, even in our own internal dialogues, that we can change our lived experience, our pain experience, without changing the underlying tissues sometimes. A last one, a really persistent one that you can see in a variety of settings, is this word have. Often it's used in the association with a condition or a phenomenon or a ailment that someone has assigned to you. Linguistically, to have indicates possession, in English at least. To have something indicates there's an aspect of ownership, something that is part of you. There's that integration of that piece of an experience that will make it harder to let it change. To say I have persistent pain, or I have chronic pain, or I have a bad back, or I have bad knees, or what have you, changes that language such that you no longer, even if you want to make change, to describe yourself as having something stymies that process. Shifting your language from to have to something like I experience, or I've had chronic pain, or I've experienced chronic pain, or I experience chronic pain indicates an aspect of transience. An experience is something that changes. It's something that is momentary or shifting. So considering the way that you speak to yourself and speak to the things that you experience and live with can impact your lived experience with pain. Moving forward to a different aspect of things, those were kind of dialogues about talking to ourselves and speaking in our own internal dialogues about what we're feeling in our bodies. There's also impacts with our experience of pain from the stories other people tell us. Anecdote and proximity are some of the most powerful biases that can affect your opinions and feelings. If a family member says, "Oh, you hurt your back, you shouldn't do anything, you're going to create so much more pain," that type of linguistic dialogue shifts away your ability to do things. Your brain goes, "Oh, if someone I trust is telling me that I shouldn't be doing these things, I should stop moving." Or if someone is telling me that, "Oh, you're probably in a lot of pain right now," and it's someone you feel that has value to your life, that type of dialogue can actually facilitate and increase the experience of pain you're having. Experiential biases can also affect these health outcomes and these pain perception outcomes. If you've had a previous injury that took a really long time to heal and you have a new injury, those previous learned experiences and concerns about how long the injury took to heal will affect the current injury as well and increase its length of time before recovery occurs. There's also considerations about the context of who's telling you this information. Let's say, for example, a family member versus a stranger are telling you of their experience of a knee replacement. If you have a family member that had a great experience with a knee replacement and they're doing really well, that story will, if you were to have a knee replacement, improve your outcome versus a family member telling you that they had a bad time, as opposed to the stranger telling you the same information. Which one would have more value to you? If a stranger came forward and said, "I had a great knee replacement, things were fine," and a family member said, "I had a horrible knee replacement, things were not good," which one would impact your experience of that knee replacement or your experience of that pain after the knee replacement more? In the same context, you can look at a medical practitioner versus a family member giving recommendations. Typically, seniority and the recognition that a medical practitioner is someone that's trained should bias someone towards taking their knowledge over someone that is closer socially to you. But sometimes the opposite can occur. If someone's had bad experiences with previous medical practitioners and a new one comes forward saying, "Hey, this is what you might be able to do," and a family member comes forward and says, "I don't know if I agree with that person," suddenly the validity of their argument becomes less. If a medical practitioner, for instance, comes forward and says, there's a persistent pain condition that you're experiencing, it can change. And a family member comes forward and says, "I've had this condition forever and no one's been able to make it change for me," which one is going to impact your experience of pain more? In a very strange but relevant socially piece, you have a social media influencer, someone with 15,000 followers. This might apply more to generations like mine or younger ones or others even. Sometimes on YouTube, you get these influencer individuals that come forward with these new trendy fads about rehabilitation or nutrition or things like that, that might actually have no context but the following that they have. Versus a new medical practitioner with current evidence or current research about a rehabilitation process that should be useful. If the social media influencer with 12,000 followers comes forward and says, "This is the way you should be doing it," and the medical practitioner with a smaller group or smaller social circle tells a different story, often in a lot of groups, in certain groups, especially impressionable ones, the social media influencer's information will overlap and take over the medical practitioner's information as well, disregarding the evidence that's more effective from the medical practitioner. These type of dialogues and the stories that other people tell us will impact how we respond to treatments, how we respond to emotions, and how we respond to pain. So how do we reframe these narratives in our heads, these stories other people are telling us, these stories we tell ourselves? It falls back under those three simple principles that I've talked about every lecture kind of at the end. The first one is sleep. Being able to sleep and effectively recover with rest decreases our anxiety, decreases the amount of stress hormones that are flowing through our systems. And by doing so, allows us to recover and inhibit the negative dialogues that are occurring in our heads. When we're tired, often negative thoughts or thoughts that are not constructive to us thriving will become more present. So by finding a way to sleep effectively, whether that's setting a time where you turn off screens, using as many pillows as you need, creating a ritual around sleep that is the same every day, those type of things can help you find that rest and find that recovery to decrease those anxious narratives within our heads. Another thing to do is think about introspection and these reflecting on our own internal dialogues. Now, this can be a little bit foreign. Often we live in a day-to-day where we are reactive, we're experiencing the world constantly, and we're not taking time to look within or look at the dialogues that we tell ourselves as we respond to the world around us. So sometimes just sitting back, and when you have an experience of pain or stress or anxiety related to an injury, taking a moment and actually parsing apart what we just said to ourselves. If you're going to go down a set of stairs and just before you take the set of stairs, you go, I know I'm going to experience pain when I take these stairs. Stop for a moment and consider, am I actually going to, do I actually definitively know this? Or is it just that I'm relying on a random or previous experience of this sensation? Maybe this time the pain will be less. That's okay. Maybe it'll be more. Experiences change. But at least you took the time to step back and look at that. Finally, the last thing to reframe the narrative is things like doing exercise or movement, testing those hypotheses as you did in introspection, and seeing whether or not you can actually do some of the things that you wanted to do. Or taking that time and noticing whether or not we actually are doing things despite these dialogues that we create. If you're saying my body is fragile, if I move, I'm going to hurt it more. And then you also say, well, I also went for a walk for 5 kilometers today and then did a hike with a family member. That is evidence directly to the contrary. Even a smaller scale, if you're feeling like I'm tired, I don't have the energy to do anything, but then you look back and say, hey, well, at least I did have some energy because I did end up doing something in the house, or I ended up being able to clean something or cook something or do a little bit of journaling, or I'm experiencing pain, therefore I must be injuring myself. But then you notice that you also did that same activity the day prior or the couple days prior, and there was no pain when you did it then, and there was no pain afterwards. So moving and doing exercise gives us an opportunity to reframe those narratives and test those dialogues and hypothesize whether or not they're actually true. So as a quick review, just kind of for the end of this session, this about concludes where we'll be discussing today. Our body detects these sensations through these receptors. This information is conducted along those long thread-like cells, neurons, within the nerves in our body. This is all processed in the central nervous system from our brain, in our spinal cord and our brain, which acts as this complex integrating center involving many different areas that allow for thinking, fear, reward, body awareness, and numerous others. When we think about the same dialogues over and over, this neuroplastic principle, this idea that our brains can change and the patterns can become habitual, makes them adapt to the thoughts that we are most commonly thinking of. The narratives we're exposed to or we think about ourselves will reinforce those pathways and can be detrimental to our lived experience, whether that's creating more anxiety about moving, whether that's facilitating our pain experience by thinking about it in a destructive way. So as a last thing, I'd like you to just take some time within the next week as a self-reflection exercise. What do we tell yourselves about your lived experience of pain or anxiety or whatever thoughts you might have? When you're wandering through the week, take those moments. If you feel like things are getting overwhelming, stop, take a deep breath, and analyze what you've previously been thinking about. Or have a notepad or pull out your phone and write a note every time you think about a certain dialogue, or every time you think about there's something you can't do. Take a moment and write those things down, and then at the end of the day, maybe explore them. See whether or not they're actually true. You'd be surprised for how infrequently our brains tell us things that aren't actually true of our lived experience.